started your timer and here is your question. Right, so if you have read and understood considering the clinical examination station, can we begin?
I will enter the room and wash my hands.
Yes.
Hello, I'm Dr. Muhammad, a surgical doctor. We have been asked to examine the lump on the right side of your face. It will include looking and feeling. I also would like to examine your neck. Are you okay with that?
Yes.
Thank you. May I confirm your name and age, please?
I'm Tom, 56 years old.
Nice to meet you, too. Can you sit down in this chair for me?
Yes.
Okay, thank you. Can you lower down your gown, please?
Okay.
Okay. Start by general inspection of the patient to see the general condition of the patient. If there is any respiratory compromise of the patient agitated, then I will inspect local inspection of that there is a lump overlying the right parotid gland side, elevating the right tubule of the ear. It is 5 by 4 centimeters and it's oval in shape. The skin over it looks there is no surgical scars, no dilated veins, and the other side is normal. There is no swelling, no surgical scars, no dilated veins. Can you clench your teeth, please?
Yes.
Okay. Now, can you open your mouth, please?
Yes.
I will use tongue depressor, looking for stents in stomach, looking for any signs of inflammations. Okay. Now, I'm going to feel for the facial nerve involvement. Can you raise your eyebrow, please?
Yes.
Okay. Can you close your eyes? I will try to open it.
Yes.
Just resist me. Okay. Can you blow your cheek?
Yes.
Okay. Can you smile for me, please?
Yes.
Can you tense your neck muscles?
Yes.
Okay. I will assess the facial nerves by on the both sides. After that, I will palpate your lump from behind. Are you okay with that?
Yes.
You pain in your lump?
Yes. No,
Okay.
not that much negligible. Yes, continue please.
Okay. I will start by palpate for any temperature.
Yes.
Then I will palpate for any tenderness.
Yes.
Meanwhile, I will look at the eye of the patient if there is any greenness.
Yes.
After that, I will palpate for the edge, regular. Then I will palpate for the if it's attached to overlying skins, or can you clench your teeth again, please?
Yes.
Okay, if it's attached to underlying structure. Also, I will palpate for the consistency. It looks firm.
Yes.
Then I will Then I will palpate for compressibility or it's reducible. Then I will palpate for the lymph nodes. I will start by submental and submandibular, periocular, and postauricular, superficial and deep cervical lymph node. After that, I would like to do my manual palpations. I will wear a gloves. Then I will, by the middle and index finger, I will insert the finger inside your mouth. Are you okay with that?
Yes.
Okay. And with the other side of other hand, then I will palpate for any stones or the deep part of the gland. Okay, there is no signs of deep parts impalpable. After that, I will do the transillumination test. Can we dim the light of the room, please?
Yes.
then with the corner of the paper receives any transformations, then I would like to do the auscultation, look for any thrill.
Yes.
Okay. Okay. I would like to complete my examinations by doing the ENT and also examine the other salivary gland. Thank you so much. You can dress right now. Do you want any help?
All right, good. You still had 1 minute and 35 seconds, but can you present your examination now, please?
Okay. Today I have examined 56 years old male who presents with lump on the right side of the face. On the general inspection, the patient looks calm. There is no specific and not agitated. On local inspections, there is a lump overlying the right side of the parotid gland, measuring about 4 by 5 centimeters.
Yes.
And the skin overlay looks normal, no signs of inflammation, no surgical scars, no dilated veins, and it's oval in shape. On palpations, the gland is not tender and it is normal.
So
and
what are your
firm.
differential? Yes. So what are your differential diagnosis?
My main difference can be infective. My main differential is due to benign new lumps such as polymorphic adenoma or Warthin
Yes.
tumor. Also, it can be due to malignant such as adenocystic carcinoma or squamous cell carcinoma, or it can
even
be
could
infective.
Yes.
Infective. Yes. Such
Keratitis or
as
lymphoma.
parotid.
How would you confirm your diagnosis? What investigations would you ask for?
Yes, after history and examining the patients, I will order investigation like ultrasound, CT, or MRI. Look for any local or bone or perineal incision.
Yes.
Also, would like to do final aspiration cytology.
Good. What are the treatment options that can be offered to the patient?
I will discuss in MDT, and patients might require superficial pyridectomy.
Depending upon the
Yes.
cause or the result. Very good. Okay. Thank you.
Thank you.
Can you just tell me what were the lymph nodes that you would be examining? Just for the sake of, yes, for the sake of just.
The submental,
yes.
submandibular, and pre and post auricular and superficial and deep cervical inflammation.
Okay, good. Right. Thank you. And here is your question. Right. So if you have read and understood, considering the communication skills question, can you begin?
Okay, ma'am. Hello, I'm Dr. Saidur Rahman, one of the surgical doctor. May I confirm your name and age, please?
Doctor, I'm John. I'm 45 years.
Okay, John. Nice to meet you. I have been told that you want to take this decision.
Well, I met with an accident, but now I'm very fine. So, what to do at hospital? I just want to go home. I have work at home.
I can explain what is your condition and what is your diagnosis. You have a RTA, and you have we suspect that you have an organ that present on upper part of the left side tummy, and we diagnosis that ischemic hematoma, that means collection of blood around the capsule of the spleen. It may be due to RTA and causes fracture of your 10 ribs. And your report showed that your hemoglobin drop continuous hemoglobin bleeding, and if it is a continuous bleeding, there is a chances of deteriorating, and that is causes danger your life.
Understand that, doctor, but as you know that I'm feeling totally fine, and moreover, staying at hospital is totally disappointing and frustrating.
Okay, I understand, but yeah, as reports say that your hemoglobin is dropped, so it is maybe become danger. So we want to observe you at a hospital. I know that staying in the hospital is frustrating, but you have to know that why people keep in the hospital when need absolutely necessary, and that's why we want to keep you in the hospital.
I have to take her to the doctor's clinic, to the GP. Nobody's there at home to take her over there. So I'm the only one. I have to go.
Okay, I'm so sorry to hear that your wife has cancer. I definitely understand your situation, but you have to look up your health first, because you say that no one is available to your wife in the doctor. So first of anything happened to you, then your wife condition become very bad. First of all, you have to look for your health. And if you want, I can contact the social worker that he can find out a way to way to take him in the hospital. And after your condition improve, we can discharge you.
Okay, doctor, that can be done. But I'm also having a job interview coming up for a pay hike. I'm really in debt, and which is going to be tomorrow morning. I have to be there.
It's also important, I know, but you should you're on danger because there is a continuous bleeding. So if you can go with this document that in future, or if possible, then online any online interview is possible, then you can contact with them.
On this, you won't listen to this. I have to go. I really don't want to stay. I'll come up later on, but right now I want to go.
Okay, I cannot discharge you medically, but if you want to go, then you have to sign some documents like you understand all things, and you to rest in hospital, and you go home with against medical advice, and every your responsibility.
Yeah, okay, doctor. It's my responsibility. I want to go. That's fine with me.
Okay. Can you repeat it what I say, that I can understand that you understand everything?
Yes, doctor, you told me that I got an injury to some organ in my tummy that is bleeding a little bit inside, and there are chances of deterioration of my condition. But I take the responsibility of leaving the hospital on my own. You have told me to stay, but I'm going by my own. And, that's it.
Okay. I have say you some sign like that. If you have feeling drowsiness or a severe unbearable tummy pain, you can if feeling that's not good, then please attend to our emergency as soon as possible. and I will give my contact number. You can contact with me, or you can contact directly to the our doctor at in charge. And
Okay.
okay, I summary what we discussed today. Okay.
Yes, sure.
Okay, we discuss that you have an ischemic hematoma, and we want to keep you in the hospital for observation, but you don't want to stay in the hospital. I discuss about your what will be the chance of happening and your danger in life, and you understand everything, and you want to go home with your own responsibility. We also discuss about what sign you have to look, and you advise to attend in the hospital. Okay.
Okay, doctor. Thank you.
Okay. I give my number in the nurse station, and if you need any help, don't hesitate. Please call me, and I will help you. Thank you for
Thank you very much.
understanding. Okay, thank you.
Okay, you still had 45 seconds left. So if we can begin and give
Okay.
feedback, it was DAMA. So broadly speaking, we covered all the points, but there are certain points that can be improved or should be improved or needs improvement in order to be considered
Yes.
to be passed. So yes, I'm just waiting 10 more, 15, 13 more seconds for it to end.
Okay.
Would you want to give feedback first? How did you feel as being a patient? What was your feeling? Did you realize good conversation was going ahead?
You can continue, ma'am.
Yes, I'm asking you to give feedback first.
It was just the beginning. In the beginning, I just felt as a patient that too much of the information was being given just in the starting. I mean, a few pauses with the small one-liners can be the thing with which it can be started.
Yes.
Otherwise, the doctor was only talking like for 15-20 seconds. And he said a few words like RTA and SPLEEN initially.
Yes.
And later on realized that he had said it wrong. I mean, the medical term he has said. And then he changed that. I mean, that was okay, he changed. But a lot of information in the beginning, I think, should not be given. Rather than that, starting with small information, then continuing that, rather than going through all the chunks of information in the beginning.
Okay, right.
That's just my...
Yes. Now, all of you, since all of you are going to appear in the exam, just suppose a DAMA station comes. Just suppose, okay, the same station comes in the exam. How would you start the conversation? This is very important. Patient is inpatient, hospitalized, and patient is hospitalized and patient wants to leave against medical advice. So how would you've entered the room, just suppose, just like we're imagining in the real life, you've entered the room, you've greeted the patient, you've introduced yourself. What would you do next? Yes, Dr. Varki, please. Yes.
I just wanted to ask that question. Will the name of the patient will be given in the stem?
Yes,
so that
definitely.
if it is given and
yes,
call the patient by the name.
You'll you'll name and age will be given. So you'll enter and you'll confirm. Are you Smith, 48 years old? Can I just confirm that you're Smith, 48 years old? So, or how are you doing, Mr. Smith? Can I just confirm that you are 48 years old? So, like, you have to confirm the patient. You cannot ask the patient your name and age, because here patient is inpatient, admitted. Or maybe you can ask, how you feel, like after you've confirmed identity, next question would be, how are you feeling now? Because you are meeting the patient now. So you'll ask, how's it going? How are you feeling? Like whatever is the regular way of greeting and asking the patient. Yes, someone is trying to say something. Yes, please.
Yes, whether the patient is having any band or something on his hand since the
Yes.
patient is an inpatient. So we call him by the name and just check the band. I'm just checking the band and asking how are you today? What happened? Like, is that okay?
Band checking, yes, when patient is critically ill, you can say, but here patient is speaking, patient is frustrated, patient wants to leave. Maybe the stem will be that patient has asked you to come down and talk to the patient because patient wants to leave. So this kind of scenario would be there. So it's better to make sure, beside it will be given in the stem, so you will enter and you'll say, okay, is it Mr. Tom, is it Mr. Smith, whatever, or John, whatever the patient's name is. So you have to confirm the identity first instead of asking. Yeah, so your question was right. And then you will ask, how are you feeling now? Patient would say, I'm absolutely fine, I want to go home. Oh, really? Then you can maybe start like you can begin and you can start telling, okay, let me explain it to you. I don't know how much you know about your condition right now. Then once you are telling, then you can even say, I don't know if you were, when you were beginning, you were explaining, did you mention about the drop of blood, Dr. Shahidul Rahman? Did you mention about?
Yes, ma'am.
Yeah.
I said that
Yes.
your hemoglobin is 10 to.
Okay, he
Yes.
did. All right, good. Yes. Right, because I realized you covered most of the points. This is what I said, but then we have to improve. That's why I'm telling you all this. So another thing I want that your conversation should have confidence in it. Like whatever you're telling the patient is a layman. You're the boss there. Your tone, your voice, everything, your body language, everything should be depicting that you are deciding that patient should not be going home, and you are explaining the risk factors and everything. So one thing was right that you told about the DAMA form. One word, legal document, you can add one little word because it's an official document. So you can say legal document. If something happens to the patient, when patient goes home, dies or something, or so patient will be responsible himself or herself, not you. So it is a very legal and official document. So rest of the thing, like the way you check the patient's instinct, that patient is making a decision, a conscious decision. So you did that. So that was good. You summarized and you even ended with a very good note. But then if you would have done this little extra talking, then this extra 45 minutes would have been covered. Good.
Okay, ma'am.
Started your timer and here is your question.
Okay.
Okay, so if you have read and understood, considering the clinical examination station, kindly begin.
I will clean my hands with alcohol rub and enter the bay. Hello, I'm Dr. Varki, one of the surgical doctors. May I confirm my name and age, please?
I'm Tom, 49 years old.
Nice to meet you, Mr. Tom. Today, I've been asked to examine your nervous system, which includes looking, feeling, and moving your hands and legs. Are you okay with this?
Yes.
Okay. Okay. Can you please your eyes, keep your feet together and hands by your side, and then close your eyes so that I can check. Okay, I will be standing beside you and will be supporting you in case you fall.
Okay.
Okay, that's Romberg sign. Then can you
First
please
of all,
walk
you'll
towards
ask the
the
patient
wall?
to stand up for you, then Romberg sign. Okay, good. Next.
Yes. Can you please walk towards the wall?
All right.
Okay. Can you please turn back?
Okay.
And can you please walk on your heels? And
Okay.
now walk on your toes.
Okay.
Okay. Now I'm going to ask you to walk in a straight line with your one foot just in front of the other. Can you please do that?
Okay.
Okay. Then now that's it. Thank you. Now please take a seat.
All right.
Can you please repeat what I'm going to say?
Okay.
Can you please repeat British Constitution?
British Constitution.
Okay. Can you please look at the tip of my finger? Do not move your head and move your and look at the tip of my finger with your eyes only. Do not, and fix your head. Okay. And I will be moving my hand in a net shape, the extraocular movements. Now,
Okay.
thank you. Can you please open your mouth and say ah?
Okay. Ah.
Can you please cough for me?
Yes.
Thank you. Can you please shrug your shoulders? I will be trying to push it down.
Okay.
Excellent. Can you please turn your head towards my hand on
Okay.
the right side? Now on the left side. Okay.
Yes.
That's good. Now I'm going to move your hands. So are you having any pain at your shoulder or your elbow joint?
No.
Okay. I'll be as gentle as possible. Can you give me a right hand? So I'll be moving his right elbow and pronation and supination, and we'll be repeating that on the left side as well. Now I'm going
Okay.
to tap on your elbows. If you have any pain, please let me know. I will stop and I will check his biceps reflex and triceps reflex on the both sides and also the supinator reflex. Then I ask him, can you please stretch your hands, arms forward with
Okay.
your palms facing up. Close your eyes.
Okay.
Check for pronate sign. Then next, I ask him to repeat the thing, like please extend your hands forward with your palms facing up. I will be trying to push your hands down. Please try to maintain it at the same position as itself. And I will try to check for rebound phenomenon.
Yes.
Then now you have to touch with the tip of your finger on my fingertip. Then you touch the tip of your nose. We have to do it fast.
Okay.
And I will be moving my hands around, try to follow my hand and touch the tip of my finger.
Okay.
And I will be looking for past pointing as well as intentional tremor on both sides. Now I ask him to repeat I will show him my disc diadochokinesia to how to check. And I ask him to do that with the palm of his hands on both sides. Okay. Now I'm going to, and now can you please lie down?
Okay.
Okay. Now, I'm going to move your legs, including your hip and knee. Do you have any pain at the moment?
No.
Okay. I will check for the tone. I will lift the leg lift test. I will lift the knees on both sides and check whether the is remaining touched to the bed. Now I do a leg roll on both sides and see whether the remaining floppy. And that's how we check the tone. Now I'm going to tap on your knees and also the angle. If you have any discomfort, please let me know. And I will check for the knee reflex on both sides and also the ankle reflex on both sides. And now, can you please lift your right heel and can you please bend your knee and bend your right knee, touch the left knee with your right heel and slide it down on along your leg.
Okay.
And can you please repeat it on the opposite side?
All right.
Okay. Thank you so much. Thank you so much. That completes my examination. Now you can get dressed.
Okay. Good. Still have 30 seconds left. All right.
Okay.
Anything you missed? Tongue examination, hypoglossal nerve examination.
Okay. Yes.
Yes.
Can you please out your tongue? Okay,
Yes.
and now thank you. Now, can you please push my finger on with your tongue on
Both cheeks.
both sides? Okay, thank you.
Very good. Now maybe few seconds. Right. Can you please summarize your examination?
Today,
now?
I have examined Mr. Tom, a 49-year-old gentleman.
Yes.
And on examination, he is having unsteady gait.
Okay.
Positive, not able to do the tandem gait, and the patient's Romberg sign is negative. He is having
Yes.
staccato speech, and there is no nystagmus, and the last 4 cranial nerves are normal on both sides.
Yes.
On examining the upper limb, the patient is at normal tone, normal reflexes, and the patient is having incoordinate, suggest positive rebound, pronator sign, dysdiadochokinesia, intentional tremor, and also pass pointing.
Good. So what are your
Lower limb.
differential diagnosis?
Yes. My differential cranial fossa tumor. I would
Yes.
also like to consider cerebellar mets, cerebrovascular accident, trauma,
Yes.
head trauma, and also multiple sclerosis.
How would you confirm your diagnosis? What investigations would you ask for?
I would like to get an X-ray of the skull to
Yes.
for calcifications.
Yes.
An MRI scan, CT scan will not be helpful in the initial stages, but it can be helpful for follow-up after surgeries.
Considering your primary diagnosis, what is the treatment option that can be offered to the patient?
If it's a posterior cranial fossa tumor, I would like to excise the tumor.
Okay. Can you name few posterior cranial fossa tumors?
Yes. Astrocytoma,
Yes.
then medulloblastoma,
Yes.
then hemangioblastoma, choroid plexus papilloma and carcinoma, desmoid tumors, ependymal carcinoma, then secondaries,
Yes.
then it
very
can
good.
be gliomas, glioblastomas, then also neuroectodermal tumors.
Very good. Okay. MRI, well, that's one. Okay. How would you want your MRI to be?
Gadolinium enhanced MRI
Very
scan.
good. Excellent. Good. Very good. Thank you.
Thank you.
Timer, and here is your question. Right. So if you have read and understood, considering its surgical and administration, kindly tell me what is the organ you're looking at, please?
Stomach,
Okay. Can you please tell me the parts of the stomach?
fundus, and body, and the pylorus.
All right. Very good. Can you please both tell me the blood supply, both arterial and the venous, please?
Arterial supply in lesser curvature, there is left gastric artery and the right gastric artery. In the greater curvature, there is right gastric oblique and the left gastric oblique and the short gastric from splenic artery.
Good. And the venous drainage as well, please.
And venous drainage is left gastric vein and the right gastric vein, and short gastric vein and right gastric oblique and the left gastric oblique.
They drain in which vessel?
Left gastric artery and the right gastric artery drain in portal vein, left gastric oblique وshort gastric in splenic vein, right gastric epiploic in a small in superior mesenteric vein.
Vein, very good. Okay. Right. Can you please tell me the surface anatomy of the pylorus?
Again,
The surface anatomy of the pylorus?
surface anatomy of the pylorus.
Yes,
it is transpyloric plane. It is
Yes.
an imaginary plane between halfway between suprasternal notch and the symphysis pubis
Very good.
at
Okay.
L1.
Right. What is the most common carcinoma of the stomach?
Adenocarcinoma.
Okay. What treatment alternatives can be offered to the patient who has a carcinoma?
What
in
treatment?
the treatment options can be offered to a patient who has a carcinoma in the antrum of the stomach?
Excision and bypass.
Okay, there's a name for it, this procedure. Can you please tell?
Sleeve.
Okay, good. Can you please, I think this is the next image. Yes. Yes, this is. Can you please tell me what kind of image are you looking at?
It is X-ray barium swallow.
Okay, of a barium swallow. So this, if you look at image A, can you please tell me if you can identify these labeled structures? What is 7, what is 6, and what is 3, please? When barium swallow has is done, in which conditions? Or what are the indications of doing barium swallow?
Any structure in esophagus.
Okay.
Can we it's number numbers it is esophagus for esophagus.
You have to tell me. I'm asking right now. Okay, can you please? I'll make it simple for you. Can you please tell me the extent of the esophagus, where esophagus begins?
Esophagus begin from T6
Good.
at the
Low border.
crooked.
Yes, good. Okay, can you please tell me here in picture B, there is this indent. Can you please tell me why there is this indent?
Maybe aortic arch or
yes, or left
or,
atrium or left bronchus. Very good.
left
Okay.
left bronchus.
Okay. In this image C, you can see between 5 and 9. This is 4. Why there is this kind of appearance? What does this tells you?
It is non-relaxed of lower esophageal sphincter.
Very good. Okay, can you please tell me what is the blood supply of esophagus?
For upper third by inferior thyroid artery, and middle third by aortic branch, and lower third by left gastric artery.
Very good. And the venous drainage
And
as
inferior,
well, please.
inferior brain.
And the venous
again?
drainage as well. And the venous drainage as well, please.
Venous drainage by inferior veins and azygous veins and the left gastric veins.
What is the cell lining of the esophagus?
Squamous epithelium non-keratinized.
Stratified squamous. Okay, can you please tell me what is Barrett's esophagus?
It is a metaplastic change of lower third esophagus. From stratified squamous to columnar epithelium.
Okay.
It's by chronic irritation.
Barrett's esophagus, untreated Barrett esophagus can lead to, or is lead to development of which kind of condition?
Malignancy.
Adenocarcinoma, yes, malignancy. Very good. How would you differentiate Barrett's esophagus with ecclesiocardia? What is ecclesiocardia?
Ecclesiocardia, it's neuropathic disorder
Yes.
in which lower esophageal sphincter unrelaxed.
Yes. How, if you'll take the image or if you'll take a sample of this ecclesiocardia, how would it appear under the microscope?
It is a loss of neural neural plexus that's responsible for relaxation of lower esophageal sphincter.
If a person has a condition, what are the complications that can result if there is obstruction or a stricture in esophagus, or just say in the middle third? How or what are the complications that can occur or result?
I think difficult of swallowing, chronic irritation, metaplastic epithelium, or carcinoma, or maybe suction pneumonia.
Yeah, perforation leading to, yes, perforation leading to pneumonitis.
Posterior metastenitis.
Good. Last picture, please. If you can tell, what are you looking at?
It's stomach.
Okay. And what kind of image is
and
this?
by lower, it's X-ray barium swallow on the stomach and the first part of the duodenum.
Okay, good. Very good.
There is pyloric stenosis.
Yes, good. Thank you.